Good morning everyone. So thank you Dr. Samendra for including me in this instruction course. So topic of my presentation is when you lose the control of your uveitis patient, what do you exactly do? Would you retain the patient? Would you seek second opinion, or would you send the patient for further treatment? So I'll be sharing 3 of my cases where I thought that I am stuck and what should I do? Should I retain, refer, or seek second opinion? So going to first case, so he is 40-year-old Indian male and he complained of loss of vision in left eye since 4 days. It was sudden onset and associated with pain. He had no vision in right eye since childhood. So at presentation, right eye visual acuity was hand movements and there was exotropia, and in left eye the vision was counting finger 3 meters, which was improving to 20/80. The IOP in left eye was high 36, there was cell 3 plus and flare 2 plus. So this is anti-segment picture of right eye, and this is left eye, we can see decentered IOL. This is the fundus picture of right eye. Right eye fundus was normal. Left eye media haze was 2. There was vitritis, few vitreous membranes. There was, you can see here some disc edema. And most importantly, you can see that there are peripheral retinitis lesion, tongue-shaped retinitis lesion, mainly inferiorly and temporally, and few satellites lesion were also seen. So the diagnosis was clinical. It was case of acute retinal necrosis left eye. And on investigation, IgG for VZV was positive. So we admitted the patient and started on standard treatment. We started him on injection acyclovir, TID, tablet aspirin. For IOP, we started on acetazolamide and topical prednisolone, atropine, and Combigan. And after 48 hours of starting acyclovir, we started him on tablet Visolon 50 mg. So this was on day 1. You can see this retinitis lesion. Even after continuing of 7 days of IV acyclovir, the vision dropped down to 2600 from 20/80, and you can see these lesions are progressing. So they have migrated till posterior pole. So you can see few satellite lesions which are actually encroaching the macular area. So even with IV acyclovir for 7 days, the lesions have not stopped. In fact, they have progressed. So now we have a patient who is one-eyed and he is having acute retinal necrosis, which is progressing despite your treatment. So what should we do? Should we continue acyclovir? Should we send him to second opinion? What should we do? So we counseled the patient, asked him to take second opinion, but patient did not want to go to any other hospital, and he said, you do whatever you wanted to do. So we went to the literature. We searched how do we treat cases of recalcitrant form of acute retinal necrosis. So there are few reports which suggest that you can give intravitreal gangcyclovir. Though gangcyclovir is not effective in cases of acute retinal necrosis, it is mostly used in CMV retinitis, but in few recalcitrant cases, they have shown that the lesions do respond. So in addition to previous treatment, we gave the patient intravitreal gangcyclovir 2 mg per 0.1 ml. And you can see that this is on day 8, the vision was 20/600, it improved to 20/320, the media is fairly better than last visit, and by 30 days, the vision improved to 20/80. And you can see that these retinitis lesions which were there started healing by day 15, and by day 30, they completely healed, leaving pigmentary changes. So this was the case 1. Coming to case 2, so he is 43-year-old Indian male. He complained of right eye blurred vision since 6 years and left eye distortion of images since 3 to 4 months. He was diagnosed as serpiginous like choroiditis and was on oral Visolon 60 mg and azathioprine. His Montux test was negative. So when he presented, his right eye showed healed choroiditis lesion. You can see hypoautofluorescence on autofluorescence, and in left eye you can see both active choroiditis lesions. You can see fuzzy margins of active choroiditis lesions as well as healed choroiditis lesions in inferiorly and temporally. On autofluorescence, you can see that healed lesions are hypoautofluorescence, whereas active lesions are hyperautofluorescence. So we advise to the pre-existing investigations, we advise him on quantiferon gold, TPHA, ACE level, HRCT and ESR, and we increase the dose to 70 mg bisolone and increase the dose to azathioprine. Since he was weighing around 65-70, so ideal dose of azathioprine was somewhere around 150. This was at presentation and this was at first week. You can see that the margin of active choroiditis lesions are more compact now, and on autofluorescence, if you can see that the margins of previously active choroiditis lesion are turning into hypoautofluorescence, that means they are healing. And on investigation his quantiferon gold was positive, so we continued the same treatment and counseled the patient for empiric ATT. But he was a bank manager, he was quite educated, so he went to Google and all, what are the indication of starting ATT, so he was not convinced whether we need to start on ATT or not. So I asked him to take second opinion, so he went to one of the good center of India and seek opinion there. So they were also of the same opinion, since he had multiple recurrences, so it is fair idea to give him a trial of empirical ATT. So after taking a second opinion, we started him on ATT. This is as 2 weeks the lesions further healed. I have not included the last follow-up. Now he had completed the follow-up of almost 1.5 years. He is off steroids, off Visolon, off azathioprine, and he has completed ATT for total 9 months, and he did not have further recurrences. Coming to case 3, he is 11-year-old boy presenting with chief complaints of whitish deposit in left eye since 1 month and blurred vision in left eye since 1 month. He had recurrent episodes of redness and blurring of vision in left eye since 1 year, on and off. He has consulted hospital A and was prescribed some topical medication. And 1 month back he had history of trauma to left eye. Following that he is complaining of redness, watering and blurred vision. So coming to past history, he went to hospital A. From hospital he was referred to hospital B. In hospital B he was diagnosed as peripheral retinal detachment with secondary glaucoma and severe uveitis and lens matter in AC, and referred to hospital C. At hospital C he was diagnosed as left eye panuveitis. So this was the picture which he was carrying. So media was hazy in left eye, and you can see some yellowish deposit inferiorly. So in hospital C he underwent some diagnostic vitrectomy, and on aqueous step there were plenty of pus cells. PCR for U bacterium was positive, and PCR for fungus was negative, and there was no atypical or malignant cell in vitreous sample. This was his investigations, systemic workup. And when he presented, he had these pictures. There were white fluffy lesions, fluffy material in the inferior part of the AC. You can see there are white large cells in AC freely floating, and there were NVIs, and you can see this suture sclerostomy port. And this is the fundus picture. Right eye was normal, and in left eye he had this whitish subretinal mass lesion in the periphery. So we have this case who was operated outside, and somewhere PCR was positive for bacteria, and AC now presented to us with some whitish fluffy material in AC, and there was mass lesion in fundus. So what do? We did ultrasound. There was thickening at the area of that mass lesion temporarily, but there was no calcification. And now CCT was also normal. There was no calcification seen. So now what do we do? Now we have the patient who has lesion which looks like retinoblastoma, but there is no calcification on B scan, there is no calcification on CT scan, but this material which is there in AC looks quite abnormal and suspicious for malignancy. So at this point of time we have to think that what should we do? We need to have a diagnosis. For that we need to take a biopsy or AC tap or material from that AC and send for cytology. But for that we should have a good cytologist with us who can actually identify, because if we miss the sample, again the diagnosis we are not able to do. So at this point of time it is always better to refer to a center where they have these facilities for analysis. So luckily we had a good cytologist with us, and we take this material from AC and send for cytology analysis. And on cytology, they showed that it had malignant small round cell tumor, which was with differential diagnosis of retinoblastoma or medulloepithelioma. Systemic workup was fine, HRCT was normal, ultrasound abdomen was normal, CSF analysis no malignant cell seen, and bone marrow, there were no marrow infiltration by malignant cell. So we started this patient on three drug chemotherapy for 6 cycle, and this is at presentation. This is after first cycle and this is after second cycle. So you can see that after AC tap, again this white fluffy material appeared. This is maybe because of chemolysis after chemotherapy, tumor lysis after chemotherapy, and after second cycle it is completely resolved. This is the fundus picture after the first cycle. You can see this mass region. This is after second cycle. This is flattening. This is after third cycle, fourth, and after fifth cycle we actually added on cryotherapy to this lesion, and following cryotherapy this completely flattened off. So when do you need to refer the patient, or when you think that you should have a second opinion? When you are treating the patient and there is still progression, patient wanting a second opinion, he is not sure what exactly he is having. Investigation when we are not having, and we actually thoroughly depend on these things to diagnose, and when the ophthalmologist is not comfortable in treating particular disease entity. So in those cases we need to refer the patient or seek second opinion. We should have an open discussion with the patient and relative regarding the current status and prognosis. And this is how we should manage patient, especially patient of uveitis or chronic diseases. So thank you for your patient care.